Our first speakers for today are Eda Jovicic and Damir Mulc. Eda is a researcher at the Faculty of Electrical Engineering and Computing, University of Zagreb, where she also received a Master of Science degree in Electronic and Computer Engineering. Her current research interest includes signal processing, biomedical engineering, and machine learning with applications. Damir Mulc is a medical doctor, psychiatry resident in University Psychiatric Hospital Vrapče in Zagreb. His current research interests include developmental neuroanatomy, affective neuroscience, sleep medicine, and biomedical engineering. Their topic for today is, can we measure depression? Recently, problems related to depression have been recognized as one of the leading issues in healthcare. Eda and Damir will talk about processing and analyzing EEG signals and record the electrical activity of the brain. Using machine learning methods, they distinguish whether there is a difference between healthy or depressed people. Can you come on stage?
Hi, everybody. My name is Eda, and this is Damir. We are happy to open today's track, Ethical AI and Data4Good, and we will tell you a bit how we use data we collected for good. So maybe Damir can start off with the presentation.
Okay, good day, everybody. Thank you, Eda, for a nice introduction. Here I'm together with Eda going to talk about collaboration between psychiatrists and electrical engineers. Those people here are involved in the process of the topic that we are going to or trying to resolve. So the title of our presentation is, can we measure the pressure? Or maybe it should be called, how are we trying to do it? So first of all, to talk about depression, we need to emphasize the impact that it has on our society, on our socio-economical life. And by the data from the World Health Organization, depression is considered to be one of the leading causes of disability worldwide. It is projected that in the year 2030, it's going to be the first disease in burden diseases. It means that it's years living with disease added with years due to the premature death, so it's going to be quite a significant problem for our society, and it is already. Besides that, it is a big problem. It also has other health implications. Then this depression is not isolated as a problem. You can see here that the relative risk for mortality or other comorbid diseases is quite high, and it makes the problem even more bigger. So what is depression? So maybe we can go to the definition of depression from the ICD or International Disease nomenclature. So depression is impaired mood. So that is the main problem, and it also is being added by the anhedonia, which means it's lack of or inability to enjoy pleasure. So those are the core symptoms of depression, and other ones are sometimes common in depression, and they are considered to be connected with the disease, and also include fatigue, sleeping problems, weight problems, appetite problems, inability to concentrate, etc. So it also is a very complex disease because numerous factors are affecting it, and it's supposed to have a causal model for developing depression as other psychiatric diseases. So maybe so big involvement of other mechanisms is making the problem of diagnosing it a bit harder. So we're trying to diagnose depression. We need to divide symptoms into 3 categories, or divide symptoms into some categories, because there is no unique clinical picture. we have affective, neurovegetative, and cognitive symptoms, but also we have personality of each individual, and it makes it even harder for a clinician or a diagnostician to make a depression. So we've invented, or psychologists have invented, some of the psychological scales which are made for diagnosing depression, but they are limited. As you can see here, that some of them are have some kind of reproducibility or other type of problems. And you can see here one part of one test, and at the naked eye you can see that they also have some kind of limits. So to go over those limits, we need to look at something that hasn't been looked before on the way it wasn't looked that we are trying to categorize the symptoms. So trying to categorize symptoms, we could come to the other types of or subtypes of depression, because we are looking at the person, we are looking at its symptoms, and we are trying to connect those symptoms and relate them to something that happened in someone's life. So at that clinical level, we are making some kind of subtypes of symptoms. But is it enough? Well, we are trying to find a biological basis that is involved in depression, and there is some kind of biological basis. As you can see here, we have different types of systems that are affected in depression: immune system, hormonal system, autonomic nervous system. They are all connected, and those biological bases may be more from the root of the problem in depression. So we can measure those biological systems, but not only at molecular level. We can measure the brain functioning, because the brain functioning is different, is a bit impaired in depression. So depending on what type of neuroimaging technique we are using, we can have different or some kind of results which are made from the impaired brain connectivity and brain functioning. And one type of those kind of problem solving in depression, it was made in 2017 by this group. They found 4 types or biotypes from depression. Those are the measurements from fMRI, functional magnetic resonance imaging, and they divided depression in 4 subtypes. So they are not divided on their clinical presentation, as I said before. They are divided on the sub-level of their biological basis. So we are trying to find some other way to measure the brain activity, and this way is used in type of an old clinical procedure that was used mainly for diagnosing epilepsy and sleeping problems, and it's about electroencephalography. So Eda is going to talk about a little bit about that. How did we manage to find the differences?
Thank you, Damir, for this medical intro, so everybody knows and understands a bit the disease we are talking about. So the method we use for measurement is electroencephalography, or EEG for short. It's a method where we measure electric activity of the brain by placing electrodes on the surface of the head. Those electrodes are usually situated inside a cap. You can see an example on this photo where a nurse is preparing a patient for measurement, and usually these electrodes, the scheme how they're put inside a cap. Here is one example how it usually looks like. Why did we choose this method? 3 simple reasons. First of all, it's non-invasive procedure. Second, it has a high time resolution. And third, it's widely available. When recording EEG, we can differentiate 5 characteristic brain rhythms. Those are delta, theta, alpha, beta, and gamma waves. Those waves appear in different frequency bands and have a difference in amplitude. What is specific about them? We can recognize, we can connect certain brain waves with the state in which a person is right now. For example, alpha waves. So if a person is laying down in a quiet room without any disturbances, with their eyes closed, usually on the EEG signal we will see alpha waves. Not only in time domain, but if we look at the signal in the frequency domain, we will see that alpha wave has the highest power of spectrum. If we check furthermore, not only one electrode, but if we check all of the electrodes used in the measurement, we can see that alpha waves appear with the highest power of spectrum in the occipital region of the brain, that's back of your head, where your visual cortex is located. So where and how do we use EEG clinically? We usually use it to detect tumors or damage to brain tissue. We use it to detect brain dysfunctions, sleep disorders, and now more commonly epilepsy, where we try to find epileptogenic zones of the brain and try to fix it, let's say fix it directly. So what do we do? How does EEG fit into our project of measuring depression? So we saw how if a person is in a relaxed state, we will see alpha waves in the EEG. What we wonder is how will EEG look like in a person who suffers from depression versus a person who is healthy. So we are trying to find the differences and trying to set a diagnosis of these between these two groups. So what we looked into was sleep EEG, EEG regulation of wakefulness, evoked potentials, alpha rhythm, and alpha asymmetry as an idea. So features from these kinds of EEG could give us some info about depression. So our work for, let's say, simple steps, it looks simple, but trust me, it's not. First of all was EEG acquisition, so we had to gather the data. Second step was signal processing, where we had to clean the data from artifacts and noise. Next step was EEG analysis, where we extracted those features we wanted to test. And the last step was classification of these features using various machine learning methods. So for acquisition, we did a steady-state EEG, which lasted for 10 to 15 minutes. We used 19 EEG channels, which replaced, you can see the schematics here. All of the recordings were done in the University Psychiatric Hospital Vrapče in Zagreb by our colleague Tomislav Slukan, who recorded not only patients, but also our control group. When we are talking about cleaning these data, some of the most common interference is CT network. Then if the electrodes were not placed properly, if they moved, so we have that artifacts also. And also all of the other electric signals that come from the body, so electric signals coming from muscles working, from your eyes blinking, your ECGs, so your heartbeat. Those are all the signals that are also recorded with EEG and are something we want to remove. So how we removed it? First, we filtered the signal. You can see the before and after. It was quite successful. Then we used independent component analysis, in which we decomposed the signal into, for example, here, into 18 independent components. And then using independent component label, we classified those components by their source. What does that mean? If we look at the component number 1, we can see that the independent component labeled it as the source is eye movement, eye blinking, with 98% accuracy. And what we want to do next is then remove this component, also the next one, because it's also probably eye with 99%. Accuracy. So what we want to do, we want to remove all of the components whose source is not brain activity. So if we look at this graph, the blue signal represents the before signal, and the red one is after. And if we look at the 20th second, we can see a big dip in the blue signal. This big dip represents a blink of an eye. And this is something we want to remove. And when we use ICA, we can see that in the red signal, this was successfully removed. Next up was feature extraction. We extracted these 5 features: wavelet energy, absolute and relative power, spectral centroid, and wavelet entropy. We chose these features by looking into what other research groups tried and which showed more success and less success, and this is what we did. And next up was use these features with supervised models. So input data were these features. Output class was diagnosis. These diagnoses in the given examples was set by our doctors, so by the medical workers, and we tried to make the best model, the best in terms of doing the best generalization for all of the patients that we tested. So here are the results. Altogether, we had 475 features per patient. We used 15 healthy subjects, and we had 15 major depressive disorder patients. And for validating, we used 5-fold cross-validation. So as a result, we see that SVM and KNN models showed the greatest accuracy of 76%, which means that out of 30 patients, 7 were wrongly classified. What we asked ourselves, are all of these features necessary, and can we maybe improve our results by using a smaller subset of features? So we did sequential feature selection. Basically, it's finding a minimal subset of features for which model evaluation does not show better results by adding additional features. And what did we get as results? So out of 475, we used only 4 of them listed here. And we can see that the results for all of the models we tested improved. So now not 7 patients were wrongly diagnosed, but 4, which is an improve. What we further tried were convolutional neural networks, so a deep learning method, where we said, let's skip step number 3, feature extraction, and let's use raw signal to see maybe we will get better results. So here was the training progress. And finally, results. So instead of features, we used raw data, and we split it into signals coming from right and left hemisphere of the brain. And we also used signal only when people had eyes open and when people had eyes closed during the recording of EEG. And we can see the results. So 80% was the highest result on the validation set. We can see that's quite close to the previous results where we used features. Okay, second experiment that we tried was trying to distinguish these 2 sets of patients, so patients suffering from MDD and patients suffering from NDD and borderline personality disorder, because for these 2 groups of patients, the treatment is completely different. And we want to try and distinguish these patients as soon as possible. So we used the same methodology. We did feature extraction, and the results after training the model could not differentiate between these 2 sets, which means that in terms of methods and data use, there was no significant difference in the EEG data of these 2 patients. To conclude, we can see from the data there is obviously a measurable difference in EEG between healthy and depressed people, but we could also improve the recording methodology in some segments. Some of these conclusions also come from the medical side of view, so I will let Damir jump here and also say something about it.
Yes, thank you, Eda, for a nice presentation. So the problem is quite complex, and because of that, we need to distinguish at first most the people who have by more than one test have a depressive disorder. So we need to do much more tests, much more other molecular level findings, and then use those data to differentiate using the AI, differentiate the patients and their EEG. And beside that, also a larger sample is needed. And I think maybe new techniques would help to improve the accuracy of the model. And I think that in future it could have some of the other applications like treatment prediction, because there is very much difference in patients which present with the depression. So their treatment is not the same. As you saw before, the borderline personality disorder, open fields has mood disorders accompanied, and people are often misdiagnosed or mistreated, and thereby I think it will be very, very helpful for clinicians. I think that
So end goal of our project is to make decision support systems to help doctors give more accurate diagnosis at the beginning of the treatment.
More help, as we now use the psychological tests to have more help to differentiate. Maybe in future we will use some kind of this AI to help us to make a decision. Yeah.
Okay, that's from our presentation. So are there any questions? Okay, yeah, please.
Thanks for your presentation. What was your training set size and test set size? That was my first question. And my second question is, what was your target variable? Was it a binary classification problem where you predicted if a patient is depressed or not depressed, or it was some kind of multi-classification problem where you predicted stages of depression?
Okay, so first, considering the training size and testing size, so altogether we had 30 patients. In the first experiment, we used the 5-fold cross-validating, so all of the patients were used in this way, and we also made sure to not use the same data, same signal from a patient in the training set and in the test set. So the group of patients was pretty small. We really hope to enlarge this study to get more patients, so we are aiming around 100, 200 patients. So this is a pilot project. We aim to enlarge it. For the second question, so we did not try to distinguish stages of depression. What we did, we used in patients that were hospitalized because of this issue. So they have, let's say, a major depressive disorder. So it's not mild symptoms, it's major. And we tried to, so the classification problem was between these two groups, so healthy and major depressive disorder. And the target was set by the doctors. So the doctors set the diagnosis, which we used to say, okay, this patient should be classified as depressed, and this one should be classified as healthy. Okay.
Another question.
Go.
Were they 15 healthy and 15 depressed?
Yes. Yeah. Okay. Any more questions? Okay, go.
Can you calculate depression based on some wearable device? Not that you have this because it's so complicated. Can you use some existing one, or can you probably create some? Because it will be much better or easier if the patient or subject would have some device on them and then calculate.
Yes, of course, but I think it's for that question, because I think it's very much artifacts in moving the person.
We can do it, but do we want to do it? I mean, if you're severely depressed, are you ready to wear, I don't know, a bracelet, a headband, whatever, that will tell you you're depressed? You know, if you're depressed, then it's that stage of depression where you need immediate help, and I believe, research showed that those kinds of patients do not care about wearing wearables which will tell them if they are,
Yes, of course, but the problem is that there is no single biomarker for depression.
Yeah.
And there are lots of money involved in trying to find a biomarker, but there is no single one. This could be added to all of the existing biomarkers, so their combination might give you a more of percentage of real depressive disorder, which has its foundation in, we could say, brain impairment. Impaired work.
You already have devices that will tell you about your mood. So you have headbands with one electrode, which is placed, I don't know, on the front or on the side of your head, which tells you in what kind of mood you are. And it's a kind of biofeedback technology where the idea is you are listening to music, and the music that is played, so if you're in a bad mood, the music played is thunder, rain, I don't know, hurricane, let's say it that way. And if you manage to relax, to calm yourself, you will hear sounds of birds, of nature, and so on. So these are two different approaches. So this is really a clinical approach to this disease, and not so much in the wearable industry, not so for home remedies.
And I need just to add to Eda that there is no single clinical presentation or picture. Different people react differently to depression. So some people are like irritable, they are moody, changing. That could be some indicators for them. So that is not that people recognize their emotions. The emotion is one part of the depressive disorder. So feeling and our understanding of feeling is one part of the problem.
Okay. Can we have one more question? Okay. You can choose, Damir.
Yeah, that's not quite. The gentleman first raised hand, yeah.
I have two questions, but first is short and the second.
Okay.
So first, how long will it take from the recording or from acquisition of data until the complete interpretation? So how long was the time period? And the second question is, as you mentioned, the alpha wave from the EEG, you were able to identify, or it is possible to identify which part of the brain is activated. Was it possible to do it for this research as well, so that you know which parts of the brain are activated?
Yeah, I'll return to one slide where you saw this after feature selection. So you can see this is relative power. So what these features tell is that a certain type of waves on certain places, so we are talking about FP1, FP2 electrode, which is in the front of your brain. So this is trying to localize what is specific about people suffering from depression. So I hope this answers your question.
Yes, it's not so selective because we are mapping the
whole brain.
whole brain. So
Yeah.
one electrode has the whole brain signals in it. So you need to use maybe more sophisticated techniques because, as I understand, I don't know that, I understand there's some kind of inverse problem to find which part of the brain did the signal come. So, but if you also know that, would it be helpful? It will just add to the concept of depressive disorder and its localization in anatomy of the brain. So that is a different type of problem. I don't think it's important at this point for trying to find a solution. Yeah.
Okay.
Thank you for your amazing talk, and here are certificates of appreciation from
Thank you.
Data Science Conference.
Thank you.